So I'm going to talk about ROP prevention. I would say that this is something which is very, very important for the two reasons. One is that the ROP is eminently preventable disease. So you can reduce this disease to a great extent, and I'll show you the AIMS data, which is in stark contrast to what you have seen. So we have the survival of very small babies, which is perhaps one of the best in the country or probably in Southeast Asia. But we have very, very low ROP. We have very small babies that stay for months together in the NICU, maybe 3 months, 4 months, suffer many different types of morbidities, are on ventilation for weeks together. But we have very low incidence of ROP. So babies between 28 and 32 weeks, bigger than 28-week babies hardly would develop any ROP. So ROP is generally a problem for us, generally a problem of less than 28 weeks. So let's look at this case scenario. We see this baby who's the pregnant mother coming at 29 days of gestation, delivers a male baby, 1128 gram, required baggy mass ventilation at birth, and developed respiratory distress, required suspected mechanical ventilation, developed sepsis, apnea, NEC, stage 2, chronic lung disease. The baby also showed poor postnatal weighting, and this baby was born and then brought to the RT center. In stage 4A, because the first screening was done at around 40 weeks, and outside it was treated with laser, but then referred to RTC AIMS. So the issue is that could we have done better? The answer is definitely yes. So in this talk, we are going to talk about a little bit of pathogenesis, how to prevent and when and how to screen in this particular setting. So ROP is a disease of preterm babies, and it results from a variety of insults that happens after preterm birth that results into dysregulation of development of retinal vessels, giving rise to the disease known as retinopathy prematurity. So you see a globe out here, and we know that the vessel starts developing at around 16 weeks of fetal life from the posterior pole, and then it migrates towards the periphery. And this happens under a very complex control of different hormones and various factors, but the two hormones are very important. One is insulin-like growth factor 1, and then another is vascular endothelial growth factor, abbreviated commonly as VEGF. So when it is happening in utero, everything goes on smoothly because it's well regulated and there is proper development of retinal vessels. But if the baby is born preterm, then this process gets interrupted, and then the retina is now premature, is not properly vascularized. So when the baby is normally fetus has got a very low saturation while the baby is inside mother's womb, it's approximately 50%. And once the baby has come out, the saturation jumps to approximately 90% even when he is breathing too well. And this can go even higher when you are providing some amount of oxygen. So this high amount of oxygenation results into down regulation of VEGF, and the IGF-1, which is the source is that of the placenta, gets interrupted. So you have very low level of IGF-1 and high level of VEGF, and that results into cessation of, so VEGF would be down-regulated because there is hypoxia. VEGF gets up-regulated when there is hypoxia. So therefore both the levels of both these entities decreases, that results into cessation of the growth of retinal vessels. Then the second stage comes, that constitutes the phase 1 of ROP. Then the next stage comes, because the retina now is a metabolically active tissue, and it's growing. So therefore there is now hypoxia because it's not supported by adequate blood supply. That results into the higher level of VEGF, but the IGF-1 is slow to increase. So you have high VEGF, but since IGF-1 is not there, therefore there is no ROP. But when this starts increasing, so that facilitates the action of VEGF, and very high level of VEGF in presence of IGF-1 would result into retinopathy prematurity. But if the vessel development has occurred properly, and then that may result into regression of ROP. So it's a complex interplay of these hormones that happens in the preterm babies, and there are two distinct phases that we see, and one is that of hyperoxia during the phase 1 that follows immediately after birth and resulting in the cessation of the growth of the vessels, and then that is followed by phase 2 where the neovascularization happens, and here the hypoxia is more important factor in the pathogenesis of ROP. So that was in a nutshell about the pathogenesis. Coming to the risk factors, there are two major risk factors for the ROP. One is the prematurity, and another is the hyperoxia at the time of birth. Then there are a host of other risk factors that have been identified for the genesis of ROP, and that includes all the measures of sickness, like fluctuation in saturations, blood transfusions, apnea, hemorrhage, infection before birth, after birth, small for gestational age babies, fetal growth restriction, respiratory distress, postnatal steroids, poor postnatal growth, sickness, etc. But there is now new understanding that it is actually the prolonged early IGF deficit that predisposes the baby to severe ROP. And the level of IGF-1 correlates very well with the fetal and postnatal growth. So that can be used as a surrogate marker. So if you have fetal and postnatal growth that is lower, then the IGF level is likely to be lower, and these are the babies who are going to suffer from severe ROP. And sickness actually acts by decreasing the level of IGF-1. So it's the IGF-1 where the story is really now focusing on. Hyperoxia perhaps acts independently. So the people have not been able to find a common ground for the hyperoxia and IGF-1, but as of now they seem to be two different risk factors. So therefore the risk factors today as of now is the prematurity is number one risk factor, hyperoxia is the second factor, and third, as a surrogate of poor IGF-1 response, the poor postnatal growth. So these are the three important risk factors. And in fact, there are the models for predicting severe ROP based on these three parameters. WinROP is one of the examples, and this is available online. Has been tested, widely used in Europe and America, but not in our countries. It requires validation. So that was the risk factor. Now coming to the prevention. So the first risk factor was the prematurity, but unfortunately prematurity is not preventable as of now. But prematurity is not preventable, but we can decrease the sickness level by using one of the commonly used seed intervention, and that's the anti-infective steroids, giving becomixazole or dexamethasone to the mom who produces preterm labor between 4 and 34 weeks of gestation. So that decreases all kinds of morbidity, and thereby the risk factors of the baby for the possession of ROP. The second factor is prevent hyperoxia at birth. This is very, very important. And the oxygen has to be treated as a drug. That's number one. And use pulse oximetry. Now we use pulse oximetry to tightly control the oxygen level. Too low is bad, too high is also bad. Now we maintain saturation between 90 and 95%, and saturation in preterm babies has been a major contentious issue in the neonatology, and there have been a lot of studies, and the recent conclusion, though it's not conclusion, but the bottom line as of now is that maintain saturation between 90 and 95. If you decrease the saturation to too low level, then the mortality is high, but the ROP may be lesser, so it's not accepted. If you have very high saturation, then the ROP is higher and CFT is higher, then that's what's not accepted. So maintain saturation between 90 and 95%, and that would be the optimum from the survival as well as from ROP point of view. Third risk factor was the poor postnatal growth, and that was a marker of IGF-1. So we cannot do anything of IGF-1, but we can improve the nutrition of the baby by early and aggressive enteral nutrition using breast milk. Breast milk contains something known as omega polysaturated fatty acid that decreases the occurrence of retinopathy prematurity. Using parenteral nutrition where the enteral nutrition is not possible, and providing adequate calories, protein, and micronutrients. This is something which is really very backbone of prevention of ROP. Then reduce morbidities by variety of means, and asepsis measures is something which is very, very important. Using protocolized approach, so that for a given situation you will do the same thing and I will do the same thing. It's not anyone's equivalent analysis. And the rational use of blood products. And the fourth thing is having a screening program, and that's where you join hands with us. And that's where your role lies. Otherwise, prevention is the domain of pediatrician. But you make a very important component for this fourth step, which is a very, very important step, that we have a team for the team and a program, and for screening of these babies that has got a protocol, a schedule, procedures, supplies, recording system, education, and follow-up. You have to have everything. Unless you have a program, you will not be able to do a good job. So in newborn units, and perhaps that's true for the babies that are managed well. So babies less than 32 weeks, less than 15 grams should be screened routinely, and the bigger babies require, if they are stable, I think the screening is not properly indicated. And hardly ever these babies, if there was no problem, would develop ROP. It's only if they were sick because of one or the other reason the ROP would happen. And because many of these babies, the data that are being shown are outcome babies who suffer variety of morbidities and referred by, because the people, those are sitting on the diets are the doyens in this field, so they get referred from this movement part of the country. When to screen, I think, has been discussed. I can communicate comment. Our ROP program is there for last 20 years, thanks to our forefather and Professor Azad. We have a schedule, a fixed day, fixed time, a fixed team. The ophthalmology will come to NICU, a pediatrics team. Identified people would be there, a nurse would be there, a doctor would be there, they identify eligible babies, they would hold the babies who have been discharged, fill up at the form, begin the pupillary dilatation, monitor the examination and do the counseling of the parents, and ophthalmic would screen the babies, decide for systemic examination, do the laser if required, and counseling and follow-up. And ROP program is an effective preventive step for any ROP. But you have to have a program. It's not the ad hoc. In the first case, it was an ad hoc sort of program. It was not a program, it was an ad hoc approach, and that resulted into partial retirement. This is our data. We have survival of babies 28 and bigger to the extent of 90%, and maybe at 26 and 27 we have survival of approximately 50 to 60%. Less 25 weeks and lesser we do not have very good survival. So you can see that our programs started in early 90s, and our laser there at that time the survival of small babies was not much. Now our survival in small babies have actually improved dramatically. But you can see the severe ROP, just wanted any ROP, because many babies would be any ROP. The severe ROP rates are very, very less, even in the smallest of babies. So hardly there will be 3 or 4 lasers in NICU every year. That's all. I think this is all about prevention. So once again, I would really like to highlight that this is a disease where the prevention is eminently possible, particularly of severe ROP, and that's what concerns us today. Thank you. Thank you.